So our next speakers are from the incredible Palliative Care Service who work day in and day out to promote quality of life for people. Please welcome Nicole, Cairns and Therese, Hayden.
Can you hear me? Can you hear me? Yes. Okay. Hello.
And me?
Oh yeah, this is great. So I hope it's okay, and I'm sorry to our cameraman. We don't stand still, and I thought I might fall off the stage, so I thought I'd just start down here. Is that okay? Good. Thanks for the introduction, and thank you so much for this opportunity to be able to come and talk to you all today. My name's Nicole Cairns. I'm a nurse practitioner for palliative care, and my amazing colleague Therese Hayden is a clinical nurse consultant for palliative care. And I'd just really like to start this presentation by saying we don't normally dress the same. We both have a favourite green shirt, and we forgot to text each other to say, hey, when we go to Mark Hughes, are you wearing the green shirt or will I? So we don't normally dress like twins, but here we are. So we are part of the John Hunter Palliative Care Service, and the John Hunter Palliative Care Service is a nurse-led service. So go the nurses. And our role at John Hunter is to do patient consults. We spend a lot of time with patients and families talking about symptom burden. And I guess our role, how we differ from nurses on the floor, is that we have the autonomy to be able to make some suggestions about medications and give our neurosurgical teams a little friendly nagging.
Help.
Friendly nagging to manage some symptoms for our patients.
So if you're in the John Hunter, you'll see a gaggle of doctors everywhere. You know, they go here and then they go. We don't have any doctors in our gaggle. There's just us two nurses. But the doctors refer to us, so that we're a consult service, like Nick said. So when they need some help with palliative care, they ring us. We go and see the patient. So we don't sort of have a role like a nurse on the ward. We can make recommendations about medications, treatments, etc.
Excellent. So, can I please ask, in all honesty, would any of you be confronted or a little bit concerned if a doctor told you palliative care was coming? Yeah? Please be honest, because I feel like a lot of our time going to hospitals is seeing patients, and patients and families are like, why are you here? What's palliative care all about? And so today what Therese and I really wanted to do was dispel some of the myths of palliative care, because lots of people say to us, you should just change your name, but I'm not that powerful. I'd love to change our name, but I'm not that powerful. So we're called palliative care, but we'd love to just really dispel some of the myths, and so that if you or your loved one has a palliative care consult, please don't freak out. We're really nice, and there's a lot of things that we do, so we just would like to dispel some myths. Yeah? So, does anyone know what palliative care does? Don't be shy.
Shout it out. Pain management.
It's because if you're terminally ill, it's the pathway to heaven.
I think we just got promoted. my new friend here said palliative care is a pathway to heaven. I'm going to tell my boss we might get pay rises. I wish we were that powerful, but I understand what you're saying. Do we do some work with end-of-life care? Yes, we do. Is it the only work that we do? No, it's not. So what we would like to do is just dispel some of those myths. But I am telling my boss that I just got a promotion.
And can I just say that we might talk about things that might cause some emotions to rise in you, and where, if we touch on something that is very sensitive, we understand that. And if you have to leave, that's fine. If you need to come up to us later and have a chat about something, that's also fine. Happy to chat.
So, because in health we love a good definition. But really what we wanted to impart today, that palliative care is all about symptom management and improving quality of life. And that's what palliative care is about, and that's what lots of people don't understand with palliative care. And so if you take nothing else from our talk today, please just know that We can be involved in any stage of a diagnosis or an illness, and we've got a couple of case studies that we'd love to share with you to highlight that. But the role of palliative care is we think we are very clever at managing symptom burden. And what we know is if you've got distressing symptoms, you don't have a good quality of life. And that's where we think we're clever. And so we've got lots of things in our bag of tricks that can help manage symptoms, to make you feel better, to spend time with the people that matter and have a better quality of life. And people can be known to a palliative care service for years and years and years. So please don't be confronted by the words palliative care, because we just sort of step in and out of your journey as things go along, and you might be having a flare-up of symptoms. We come in, we do our little thing, and we can step out again. And that's what we're all about. So I think the problem with palliative care is back in the day, it used to be cure, 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 lots of intervention, a big line in the sand. Everything's failed. Oh no, nothing we can do. Now let's call palliative care. And this is, I think, where our bad name or perhaps our misconception about what we do has come from. But that's a very old school model. So what Therese and I like to bang on about any chance we get is the new model of palliative care, which, when we're looking at this, palliative care can actually be relevant at the time of diagnosis. Because if we're thinking that palliative care is about managing your symptoms, often what we know is you might have terrible symptoms, and that's what brought you into hospital in the first place for testing before you reach a diagnosis. And our role is to educate our colleagues that if you have a patient that has some horrible symptoms, call us because we think we're clever at managing those. Because how are you meant to make really great decisions or informed decisions about what's happening if you feel like crap? So we can actually be involved at the start of an illness and then just step out again. And often then, as the illness progresses, our role might get bigger. But likewise, there is also a role for curative intent treatment, can be anywhere along the illness trajectory. I hope that makes sense, and I'll tell you a little story that hopefully illustrates this. So we're going to call this lady Anna. And so she was admitted to the John Hunter, 58 years old. She knew from a scan with her GP that there was something concerning in her brain. She came to the John Hunter for planned surgery. Prior to the surgery, she had terrible headaches, but the thing that was really overwhelming for Anna was she could not stop vomiting. So it was really hard for clinicians to administer medication for her headaches because she couldn't keep anything down. She hadn't even had her surgery yet, no biopsy had been done, and we didn't have a diagnosis. We just thought that there was something that perhaps looked concerning. So the neurosurgeons called us and said, we want you to do some symptom management for Anna. And so what we were able to do, and this is palliative care bread and butter, the things that were distressing her the most was the pain and the nausea. And so what we did was we started an infusion of medication, so something running under the skin all the time, to stop the vomiting and to give pain relief, which in turn made her feel better, which in turn meant she could have the conversations with the clever surgeons that she needed to have. She then went on for surgery, biopsy, and palliative care stepped out again. So does that kind of make sense as to, we were asked to come in at the time of diagnosis, and as a patient, she was very confronted when we walked in and said, we're from palliative care, because she hadn't even been diagnosed yet. And we understand that for our patients and families, and we always take the time to say, can I please just explain what I'm here for? And then we were able to make her feel better and step out the way, and then we didn't need to see her again for about 18 months. So that's just a little bit of a story of how we can fit in a journey. Yeah? All right, we'll shut up, Therese, we'll talk now.
No, you talk this one, I'll start next one.
Okay, I'll keep talking.
He likes to talk.
We feel we're really visual learners, so I feel like everybody's got beautiful slides that are very intelligent, and here's ours with an elephant, right? But we feel like the value that palliative care brings is we stand back and look at the big picture. And so often we're called towards, and Kat and Elise will ask us to come and see patients. And there's lots of teams involved. For those who've had a lot of experience with the health system, every man and his dog's coming in and telling you something, right? Where we feel we are different is that while everybody's looking at their little bits, whether it's a rope or a tree or a snake, we kind of take a step back and go, right, how about we look at the whole picture? And then we're going to talk to the patient and family about what matters most to them. So we bang on in Pal Care all the time about what matters most, because that's palliative care is not prescriptive. We want to do what's important for you and for you and for you, and they might not be the same things. And so really our role in all of this is sometimes just to step back and look at the big picture and then be able to lovingly nag some of our teams to say what we might do is we might all just look at the big picture now. Does that make sense? Okay, Therese.
Trying to click the button. You be the button clicker. So, like you said before, we certainly do end-of-life care. That's a part of the work that we do at the John Hunter, but it is the smallest part of the work that we do. And it's the smallest part of what palliative care has to offer for patients and families. I don't know how clear that is up there. I can't see a thing. Maybe I'm so blind. But just to expand on that, so palliative care is for anybody with a life-limiting illness. Doesn't have to be a malignancy, can be for non-malignant conditions. So it might be for the patient with advanced heart failure or renal failure, or for the patient that's even been in a trauma. Palliative care is applicable for all those patients, together with patients with malignancies. And like Nick said, it's not palliative care is not an us and them approach. We're in it together. And so the patients that are known to our service go on to have their palliative chemo, their palliative radiation, their other treatments, their surgeries, whilst we're coming along for the ride. And like Nick said, we dip in and out, so our role is small or it is great. It just depends on what's going on for the patients. And of course, then we do see patients at end of life, where the focus really is on those symptoms and ensuring people are comfortable and their dignity is maintained. But the end of life care is just the tiniest amount of what we do. I think Nick and I see about 600 patients a year at the John Hunter, and end of life care is the smallest amount of what we do. Consultation. Is there something particularly you wanted to say?
No, really, I just wanted to highlight here what might happen when a team says to you, we've asked palliative care to come in. And this is just a little bit of what you might expect, but we take our role really seriously. And so when we're asked to see a patient for the first time, we'll often make sure we've got at least an hour and a half or 2 hours set aside, because I don't want to come into a really vulnerable time in your life and not have my head around exactly what's gone on for you up to this point. But then we also talk about what's going on for you, because we know you might have a diagnosis of cancer, but you also might have something else. You might have a pneumonia, you might have got COVID, you might have just broken your leg, right? So there can be lots of different reasons why you're coming in. And so we like to, again, look at the big picture and see what's going on for you. We also like to look at, are there any reversible causes? And so a big part of the work that we do is advocating for our patients, because labels can be awful. And what we've learned with our patients is sometimes if a patient is labelled as the palliative patient, suddenly that means they're not getting treatment for things that they would want treatment for. And so an example of that would be somebody perhaps who has a condition like brain cancer, and you come in with a pneumonia that's very treatable with antibiotics. Our job is to come to you and say, would you like your pneumonia treated? And if you say, yes, I do, then we say, hey guys, treat it. So we are all about your goals of care and what's important to you. And so we feel like we're just another layer, another person, another team in your tool belt to help you through this journey. But often our role is to just have those conversations and sometimes just remind our colleagues that don't be labelling my patient. Thanks very much.
So Nick and I...
Sorry,
forgot. We've been at the John Hunter now for 4 years. Before that, there was no palliative care service at the John Hunter, and we were recruited from another facility to set up our nurse-led service. And since that time, Nick and I are absolute data nerds, and this is just as an incidental, but we keep statistics on everything so that we know how to move our service forward into the future. We need to know what we're doing now and how can we further develop. But when we look at the reasons people get referred to us, these are the top 3 reasons. So for symptom burden, so like Nick said, our number 1 thing is symptoms. If anyone has a difficult to manage symptom, they'll call us, and that will be our sole role within the consultation. They might want us to talk about goals of care, place of care and community follow-up. So I think we talk maybe a little bit about it later, but outside of the John Hunter, across our local health district, there are 19 community palliative care teams. Lots of the work that Nick and I do is making sure that the patients that we see are referred to their domiciled community palliative care team, that they get a really great handover on the patient with some knowledge about what that patient's going to need in the community. And we're working very closely with our social workers, and we have a social worker on our team to make sure that those packages that Kat was speaking about before are put in place for when those patients go home. So we do lots of conversations about goals of care and place of care. And lastly, family and carer psychosocial support. So like Nick said, we like to look at the big picture. It's no point to us really looking after the patient if the family are really struggling. So we want to make sure that we're providing every support we can possibly do to the family. So sometimes the referral isn't about the patient at all, it's about the family and the carer. Joe. Joe, not his real name. That's a young man on a, what do you call that, a paddleboard? Is that what they're called? Stand-up paddleboard. He's on a stand-up paddleboard. He's not the patient, but he's a true representation of a patient that I saw, a young man that we had a consult for on one of the surgical wards at the John Hunter. And we were asked to see him because he had incredible pain that was not responsive to oral opioids. So the team were prescribing and switching opioids via the oral route, but nothing was working for him. And so they asked us to get involved because did we have an alternate way to deliver the medications? We did. What we actually did was converted everything into a little infusion that we just run under the skin, so it doesn't go into a vein, it just goes under the skin, because his goal of care was to be at home with his wife and his young family and to get back in the water again. So he was actually a very good surfer. He couldn't surf anymore, but with his little pump giving him his pain medications, he could get out on a stand-up paddleboard. And that was really what the request was for us to see him, was do something better with his pain relief so we can get him home, so he can do the things that are really important to him, which was not being at the John Hunter for months on end. And he was, I can't remember, late 30s.
Yeah.
What do you got?
Oh. So, can I go over here? Yeah, is the
Switch.
camera guy getting mad? We just wanted to say hello to this side of the room. We just wanted to highlight what services are available in our district from a palliative care perspective. So there's services like ours that are called inpatient consult services. You're in hospital, Palcare can come and see you. As Therese mentioned, in the community, there are 19 palliative care services in our district. So right up to Tenterfield, out to wherever our district ends, there are 19 services. There's heaps of them. And the good thing is we all talk to each other. And so the great thing for us as Palcare clinicians at the John Hunter is our colleagues in Glen Innes might have a patient who's coming to John Hunter and they ring us and they say, Nick, can you go and check on this patient? They're coming down to John Hunter for whatever reason, but this is what we've already talked about from a Palcare perspective, or this is what medications are working for them for symptom burden. And so the idea is that for our patients, regardless of what facility you go to or what area you're in, we're talking to each other so there's a smooth transition, and that you're not then going, 2 years ago, I saw this is what happened, that we already know your story to ease that burden for you and your family. There's also outpatient clinics in certain areas throughout the district. So they might say, we want to check on with you and see how things are going with you from an analgesia perspective. but you're well, just walk into a clinic like you would any other outpatient clinic and we can do the consult that way. Telehealth. So COVID has shown us that we can do anything via telehealth. So now we can get staff specialists to consult with patients that live 300 k's from Moree, because we've got all the technology now. So, and that's been life-changing for a lot of our patients and families who previously had to travel to big centres to be able to have those consults. Now we can do a lot of it in the home. Our outpatient services, like I said, the 19 community services, the majority of those are 24 hours a day. So, meaning when things go pear-shaped, it's normally 2 in the morning or lunchtime Sunday, and all your regular teams aren't there. What palliative care offers is support 24 hours a day, that you've got someone to call. Should I be worried about this? Could I have some advice on what I should do? Now, the last thing I wanted to touch on is the hospice. Has everybody heard of the hospice? Is anyone a little bit scared of the hospice? One person nodded, please. In our experience, lots of people are a little bit confronted by hospice. And again, if we could just dispel some myths. The hospice is an inpatient palliative care unit in the grounds of the Mater Hospital. And lots of people think that the hospice is almost like a one-way door. You go in, you never come out again. And I know I said if you could only take one thing, but take 2 things from us, right? That is so not true. It's a specialist palliative care unit. So we often say to patients, you might need to go there for a tune-up. It might be that your analgesia is not working anymore. Let's bring you in, give you a tune-up, and send you out the door again. So please don't be confronted if you or your loved one are offered a place in hospice. It doesn't mean that things are happening that we're not telling you about. It might just be, we need to bring you in for a tune-up. That's much better to do if we can give you the medication and see the effect, rather than doing it at home. So that's often what we use hospice for.
And I think it's important to recognise that all the staff specialists in palliative care in the Newcastle area sit over at the Mater in the Department of Palliative Care, which is at the hospice. So we don't have a doctor at the John Hunter, and there's not one that sits in the Mater in the bigger picture. They all sit there, and that's why it's used for, when the symptoms are potentially unmanageable, particularly in the community. They'll bring those patients in, the doctors will review them there, and then they go back home.
I left the button over there.
Oh, you want me to click it? We all have our strengths.
Did you hear that? The line behaviour, Therese. She said we all have our strengths. Carrying the button's not mine, right?
Giving orders.
Do we need to talk about this?
I'm just
Should
gonna
we
say no.
stop soon? Are you sure? You'll tell us? Yep, okay. So sometimes it's families who actually prompt medical teams to say, hey, maybe we need to think about palliative care. And now that you all know that all the great things we do and that we're not scary and that there's a whole tribe of us that want to help, you are allowed to say, maybe it's time to get pal care involved. So some of the times that we might think it's appropriate to start thinking about letting us become part of your journey, symptom burden, I can't stress it enough. We just think we're so clever at managing it and making you feel better. So perhaps your analgesia that was always working to control headaches or terrible pain is now maybe not having the same effect it was. You're starting to get some new nausea. Help me out. Breathing. Difficulties with breathing. Anything to do with symptoms that are affecting your quality of life might be a time to think about, could we get pal care involved? So that's the big thing we do, symptom management. If you're spending a lot of time in hospital and perhaps a lot of unexpected admissions, it might be time to say, hey, could palliative care maybe contribute something?
And by that could be, being linked in with the community team, and so to alleviate the need to present to hospital, have the community palliative care team perhaps come out to your house and manage the symptoms that way. Community palliative care will always escalate care if it's needed, and they work very closely with patients' GPs. So if they're wanting to change medications or anything like that, they will always talk with your GP in consultation, so that the GP is still the primary caregiver. But being known to a palliative care team in the community might just stop some of those hospital presentations.
Yeah, great point. The other thing is perhaps from a functional perspective. So if you're noticing that perhaps things are getting a little bit harder to manage, these things I could do 6 or 8 weeks ago, I'm now struggling a little bit more with, it might be time to think about palliative care, because amongst those 19 services that we talked about before, it's not just nursing and doctors. It's physio, it's OT, it's social workers. So sometimes it might just be, look, I'm okay, but maybe functionally I need a bit of equipment. Great, we'll get the OT to come to the house. So the whole thing with palliative care is that we're trying to look at the big picture. So that might be a time to think, okay, maybe palliative care might have something to offer here. And we are very much about quality of life. And so for some of our patients and families, the interventions can be burdensome. And it's actually, sometimes we're asked to talk to families and patients about, what if I actually don't keep going? What happens if I stop my chemo or radiotherapy? And we can just talk it through. So we are all about quality, not necessarily quantity. And if you're starting to have those thoughts, it might be a time to think about pal care too.
I like this one.
We feel like this is the flag for pal care. So
Maybe we should change the logo for pal care.
maybe we should. We feel like, well, I was tripping over something. Anyway, we feel like this summarises what palliative care is, and the way that we like to describe it is, imagine Therese and I had the same diagnosis, and my vision moving forward is I want every treatment, I'm going to go on every drug trial, I want every bit of surgery done. And palliative care says, that's totally fine, we'll just come along on the journey and we'll step in and out as you need us. Theresa's got the exact same diagnosis, and she says, I've had a nasty experience with chemo, I'm just picking that out of the air, and I don't even want to see an oncologist, and I'm not going down that path, and I won't do a blood test, and I'm going to Hawaii, thank you very much. And palliative care says, that's okay too, and we will come on that journey with you without any judgment. And so it's not prescriptive. Sometimes people say to us, can't you just tell us how much morphine to give? And it's like, well, I can't, because I don't know what her goals are. I don't know what Siri. So we're not prescriptive, and it's not one size fits all, because what's important to you is different to you is different to you, and palliative care respects that and comes on the journey and will just meet you where you're at. Yeah?
Perfect. And I think that's our last slide, but you can't really see it very well, but it's all really... Can you? It's about hope. Yeah, we all have hope, and we all have different goals that we want to reach in our lives. And like Nick said, in pal care, we don't make judgments about what people want to do with their life or what their goals or hopes or dreams are, but there's always a hope. And we're not here to dispel anyone's hope and to say they can't reach their dreams, but we are here to make sure, to ensure your quality of life and walk along beside you to reach those goals, whatever they are, and to ensure that all your hopes and dreams are met. Because we all have them, and they don't stop, no matter what they are. Thanks for listening.
Thank you.